Okay, why don't we go ahead and get started. Welcome everyone. It's so great to see all of you and to know of all the presence of those who aren't able to share your camera, but those who can, we love that you do and encourage all of you who can to please do so. This is our second in the Stanford Medicine Center for Improvement speaker series. We're very excited for our speakers today. And excited to continue now. The first one went well. The definition of how an ongoing program is how well you get through the second one. So we're very much looking forward to this and appreciate Maria and Anna, who will introduce in just a minute, in coming and being willing to share their thoughts with us, and for all of you for joining us. Just to give a quick background about this program, this is just getting underway, and the vision for this program is that this will be an opportunity for us to continue to develop this learning network, this learning community that we're really trying to establish here and build upon here at Stanford in improvement. And so we have a number of different types of talks, essentially, or presentations that we are envisioning. Work in progress, an upcoming presentation, an innovative concept, an educational topic, a guest speaker. So this is just kind of a list of types of things that we're currently envisioning. So the current topic is a work in progress, essentially. So in this circumstance, this is where we ask individuals to come talk to us about what they're working on, and provide a forum for them to get some feedback and get additional thoughts. So Maria and Anna have been so gracious about being the first ones to come and do this for us. So the way it works is they're going to present their work to you, and we're all going to listen very attentively. And we recommend that you be thoughtful about the type of feedback or questions that you're going to give. And so then after that time, then we'll pause, and then we'll have an open time for discussion. You can provide your thoughts. In this case, while we're very interested in the topic that we're going to hear, and that's of course an important part of this, really the primary goal is to help the speaker refine their thoughts so that they can continue to even build upon what they're already doing. So please structure your comments and your questions accordingly. Again, please take notes, ask questions, provide insights, and so forth, offer to make connections, all of those great things. And if you have more detailed thoughts that you're unable to get back to them in this time, and it's not maybe appropriate, or we run out of time for this, please feel free to just email that directly to them. Any questions or comments before we introduce our speakers and move into this? Okay, great. Well, it's my pleasure to introduce Maria and Anna. I'll start with Maria. And I'm going to go back to the slide. Maria Yefimova is a nurse scientist with the Office of Research Patient Care Services at Stanford Health Care, supporting ambulatory care nursing and patient care service professionals in their research. Her work is grounded in her interest in improving care for frail older patients through systematic change in care delivery. Dr. Yefimova obtained her BS, her MS, and PhD in nursing from the University of California, Los Angeles. Her postdoctoral fellowship training followed in the National Clinician Scholars Program at UCLA and the VA Greater Los Angeles, and she was in the 2018 to 2019 Academy Health Service Science Fellow, gaining skills in implementation science and learning health systems at the VA Palo Alto. She's an instructor with the Division of Primary Care Population Health at Stanford School of Medicine. Anna Sophia Lestokoy, I'm not sure if I pronounced that right, Lestokoy, serves as the research manager for this evaluation, and she's currently a research operations program manager in the evaluation sciences unit within the primary care and population health division at Stanford University School of Medicine. Her previous experience in health services research has included work on chronic pain in underserved patients, evidence-based integrative health approaches, and cross-cultural mental health at the Boston Medical Center and Cambridge Health Alliance. She holds a bachelor's from Wesley College and a master's of public health from Boston University School of Public Health. So with that, I will turn it over to Maria and Anna. Thank you so much.
Great. Thank you so much, David. Let me just pull up our presentation. And thank you so much for giving us the opportunity to present our work in progress, and very excited to be second group and hope to live up to the expectation of bringing up a lively discussion about our project. Thank you again for everybody for contributing to this. And I'll start off, and Anne and I will kind of go back and forth. So today we'll tell you about a new clinical program called Stanford Home-Based Senior Care and the evaluation that is concurrent with it. And we were asked to share our questions to the audience ahead of time, just so that you think about them as you listen to our presentation. And our questions are both content-wise and methodology. So we hope that somebody has had similar issues and is able to provide some insights. One of which is, has anybody compared satisfaction surveys to what they hear from individual interviews with patients? The other question is, other than comparing results found in research literature, how else can we examine effectiveness of a program without a comparison group? So that's something that we're struggling with in looking at effectiveness of this new clinical program, and how do we say that it's working if we don't have a comparison? And are there any alternative clinically relevant explanations for the outcomes we've seen in the program that we'll go over? And then how can we reliably find out if patients in our clinic-based comparison group are deceased? So that's something we're struggling with in EPIC, and making sure that, not making sure, but figuring out if patients are still alive or dead, because we're looking at mortality. And lastly, who else at Stanford Health Care might be interested in the results of this evaluation? Because we're always looking for partnerships, we're looking to disseminate knowledge, share results, and really kind of, provide the, build kind of a collection of stakeholders who might be interested in this work. So without further ado, I'd like to tell you about Stanford Home-Based Senior Care. And as you probably guess from the title, Senior Care, that we're talking about older patients, and not just older adults, but folks who are frail and disabled and maybe homebound, such as, for example, my grandmother-in-law that you can see in the picture here. She just turned 102 this year, actually this past month. And at this age, she has trouble walking and often gets confused when she is leaving her apartment, which makes going to the doctor a major challenge for her and our family. And, we keep wondering, is there anything other than traditional clinic-based care that is available for people like her? Because she's not alone in her struggle. As you can see from this demographic pyramid on the left, it will also become a pillar on the right. In 40 years, so by 2060, the number of people over the age of 80 will triple, and the number of those in their 90s and 100s will quadruple. So you can see up top, and there's also going to be a lot more women surviving into older age. We also know that on our local level, about 20% of Stanford hospitalizations are for people over the age of 65, and given the demographics, this number is going to continue to grow. So we're really seeing this change, the shift in demographics, both on a national and the local level. And we also know that advanced age is associated with many issues that are challenging to manage oftentimes in our existing healthcare system, such as multiple chronic conditions, the limitations in activities of daily living, such as dressing, bathing, and even going outside of the apartment or house. And similarly, risk of cognitive impairment, which increases with age. And all of these alone and together leads to difficulty attending clinic-based appointments. Not only does that affect our patients, but it also affects our caregivers. And friends and family and others in the vicinity who provide daily care to the older person, who coordinate appointments, assist with daily tasks, manage medical care, and provide transportation. And we know from a recent AARP report in Caregivers that about 40% experience that as a high intensity burden. So really, we're taking care not of just of the person, but of the whole entire family. And honestly, one of the challenges that we have to deal with is that it is a challenging experience, because we can see that not only does the cost of care increases with age, but the question is, does the quality as well? And this is also compounded by issues of frail patients missing care because they are having trouble attending clinics, going to hospital instead of their primary care. And so the question is, can we turn the tide of avoidable hospitalizations through a comprehensive, coordinated care that supports our social needs, such as transportation? And one of the things that we noticed both in the literature and just in general is the resurgence of this idea of doctor home visits, which happened, before we had hospitals, before we had this complex health systems. Doctors used to come to the patient's home to see how they can help. And this idea of home-based primary care models has been on the rise, both internationally and nationally, as you can see from these recent publications. And this program seems to work. As you can see from the literature, these programs reduce utilization and acute care utilization by 20-30%, such as unnecessary D-visits or hospitalizations. But the question becomes, does this work here at Stanford? Because every place is unique in how we work with our patients and kind of who we see. So this question was posed through at a business strategy meeting back in 2017, where it was noted that there is a population of frail older patients cared by SHC that have avoidable use of acute care services such as ED visits and hospitalizations, who are just not optimally served by clinic-based primary care due to, like I mentioned, functional impairments, caregiver issues, and complications of dementia. And so the idea is, as you can see on the figure on the bottom, is to bring the healthcare to patients' home and to their family. So the goals of this new program that was developed through lots of strategic meetings and business development is to basically provide the care that the patients want and support their families and their caregivers, as well as minimize this unnecessary use of Stanford Health Care services, such as ED visits and hospitalizations. And we're planning to do that, or the plan was to provide routine primary care, urgent visits, and more intensive social work management in the home environment of the patient. And the unique aspect of this program is we're focusing on older adults over the age of 65 who are Medicare beneficiaries and who come to Stanford for their care. So these are the population you can see on the map, where because it's a home-based program, meaning that the clinicians come from Stanford to the patient's home, we looked at a geographically bound area, as you can see in the map. And we looked at patients who are over the age of 65, who have functional impairments as evidenced by challenges with the activities of daily living, such as bathing, dressing, toileting, moving around, getting out of the house, or having one of those impairments and having cognitive impairment or dementia, because that really makes folks really challenging to travel to the clinic and also, provides a lot of complications in their day-to-day care. We also looked at patients who had attributable healthcare use, meaning they've had a hospitalization to Stanford, at least one in the year prior to enrollment, or at least 2 ED visits to Stanford Health Care in the past 12 months, because we wanted to really see if their utilization will decrease from what it was previously. And we really targeted those high utilizers. We also looked at folks who are homebound, meaning those who lived in private residences or assisted living facilities or memory care, so who is not a long-term care stay resident, so people not in nursing homes, because we really want folks to stay and age independently in the place of their choosing, whether it is a private residence or assisted living facility. So what are the innovative elements, as I mentioned, and how is it similar or different from other home-based programs? I think the key here, because it's a heavily geriatric population, is providing comprehensive geriatric primary care. So there's a geriatrician on the team who has extensive training in dealing with things like pressure ulcers, caregiver issues, urinary incontinence, so things that really occur a lot in the elderly population that you don't really see in an adult population. again, it's because we're looking both at the patient and their family or their caregivers, we have this intensive social work component to it, because there's a lot of issues such as and things like social determinants of health, where the person lives, who helps them, that really affect their use of engagement with healthcare. And like I mentioned, we're focusing on high utilizers of SHC care. And the idea is to work in partnership with existing home-based services such as home health and hospice, because we expect a high mortality rate for patients because they're older and sicker and frailer. So we want to use and encourage hospice care, caregiver agencies and respite services, housing placements, nutrition, visiting podiatrists. So all of that is kind of referred to or coordinated with in partnership with our geriatric primary care. So that's the program in a nutshell. But the question becomes, how do we know that it works? How do we know that it's actually providing the effectiveness, it's providing the care that the patients want and need, and that it actually is effective in reducing utilization like we hope it would? So, Anna, take it away.
Hi, everyone. So, in terms of answering the question of knowing how it works at Stanford Health Care, for the next few slides, I'll start by introducing who's working on the evaluation and talking about the different types of data we're collecting. So to start with, this evaluation is a partnership between the institutions of Stanford Health Care and Stanford School of Medicine. And what's great is that it's allowed for a collaboration between the two organizations. So they've been able to share data and build on each other's specific expertise. So on the Stanford Health Care side, we've been working with Ambulatory Care Leadership as a sponsor, as well as the Office of Research Patient Care Services, specifically Michelle Williams and Debbie Shea, who's been pulling a lot of the EPIC data for us to work with. And on the Stanford Medicine side, it's mainly been a partnership with the Evaluation Sciences Unit, working with Laura Holsworth, Dawn Garver, Darlene Garodipong, who provided their qualitative and quantitative data expertise to move this process forward. We also have Blair Humber, who's a postdoc who's been extremely helpful in terms of analyzing the data. And then in terms of kind of the central clinical and evaluation team, for the clinical team, we have the doctors who are running the Home-Based Senior Care program, Drs. Mary Shafran and Dr. Marina Marden, who span both institutions, as well as the evaluation team itself. We have Maria from the Office of Research, and Marcy and myself from the Evaluation Sciences Unit. So now you know kind of who's working on this. It's a matter of what we're doing. Next slide, please. So I have kind of an overview of the program evaluation framework through each section quickly to explain a little further. So starting on the left for inputs, we basically have all the different elements that make up the Home-Based Senior Care program, including the staff, which is almost 62% nutrition, nurse practitioner, physician's assistant, social worker, and medical assistant, as well as the home visit travel supplies and any contracted services that are part of providing care in the home. And then moving on to outputs, we have both the audience and the activities that make up the Home-Based Senior Care program. So the audience are the homebound Frail patients and their caregivers, as Maria introduced them, and the activities themselves are the home visits by the primary care provider and any kind of clinical communication, whether it be in person and by phone, as well as intensive social work follow-up. Also includes providing resources for caregiver support. And then in terms of the information we're gathering as part of the evaluation, for the outcomes, we have both short-term and long-term. For short-term, we have satisfaction with the program, quality of life of the patient, as well as their functional status, and specifically for the caregivers, looking at their burden over time. And then for long-term, as we noted before, in order to qualify for this program, patients tend to be higher utilizers of SHC care. So we'll see if receiving these home visits results in a reduction in acute care utilization, specifically hospitalizations and ED visits. And secondly, we're also expecting higher mortality for the patients who are enrolled in this program. So we've included palliative and end-of-life outcomes. And just as a general note on the evaluation itself, the IRB deemed this project to be quality improvement because the work is really meant to inform operations rather than having its main purpose be generating knowledge. So next slide, please. So in terms of the questions we hope to answer through the evaluation, generally we're interested in knowing which patients benefit the most from home-based senior care, what the patient and caregiver experience in the program is, and how we can make it better. And does home-based care lead to less acute care utilization among frail homebound patients compared to traditional clinic care? So in terms of how we're hoping to answer these questions, this is a more detailed look at our 3-year evaluation, which started in February of 2019. And I realize this is a lot of information on one slide, but basically on the left, you have all of the different forms of data we're gathering. And then the other part of this is a timeline of when we're collecting that data. In connecting back to our evaluation questions on the previous slide, if you start in the blue section, we're using patient and caregiver reported outcomes at various time points to figure out which patients benefit the most from home visits. And we're also doing in-depth interviews with patients, with a subset of patients and caregivers to understand their experience in the program and how it could be improved. And thirdly, in the gray section, in order to understand whether being enrolled in this program leads to less acute care utilization, we're using EPIC data to help identify a comparison group to the home-based senior care cohort and compare utilization patterns between the two. And then just generally in terms of when things are happening, the clinical program launched in October 2018, and the evaluation started a few months afterwards, with our first year mainly focused on setting up data collection and defining the evaluation cohort. In the second year, which is where we are right now, we've continued data collection as well as doing a lot of work in terms of identifying our comparison group. And at the moment, we're actually getting started reading our second year report to report our findings back to our sponsor. And in the third year, what we hope to do is kind of wrap everything up, including final analysis and results. And kind of the last section in orange, something I want to underline is that throughout this process, the evaluation team is meeting regularly with the clinical team to pass on any insights that can help improve home-based senior care operations. Next slide, please. So, in terms of what we've found so far, just going back to our general framework, we'd like to describe our audience a little bit better in terms of who are these frail homebound patients and their caregivers, and what have we learned about them. So just to start on our patients, we've learned that they are older, diverse, and living at home at times of enrollment. We found out that they're mostly women, which isn't too surprising when you consider general life expectancy by sex, and especially when you look at the age, that the patients are 85 years old on average, with most people over 80. We even have a few 100-year-olds enrolled in the program. And for racial makeup, patients tend to be fairly diverse. The largest percentage do identify as white, with the second largest section landing in the other section, in the other category. And those are mainly people who have written in that they identify as Hispanic or Middle Eastern or something else they felt that the other racial categories didn't cover. In the bottom part, we've included information as to where patients live, which is really important for a home-based senior care program. As you can see, in terms of where they live, the majority live in a private residence, with 33% living in congregate housing in some sites, and that includes either memory care, boarding care, or assisted living. And as far as their geographic location, this is basically a map of the codes of where patients are residing, and it looks very similar to the overall catchment area in order to qualify for the program. And then in terms of the patient's health status and care utilization, patients tend to have multiple chronic conditions and to use SHC care. So starting with utilization is our patient's utilization in the prior year. Given that in order to qualify for the program, they have to be high utilizers. You can see that on average in the previous year, patients had 2 to 3 visits to the hospital or emergency department. And a quarter of them used one of these services 4 times or more and up to 12 times within 1 year. And in terms of health status,
sorry about that.
On average, patients have 3 chronic conditions, but the range goes from 0 to 9. And what's important to note about the chronic conditions is that in terms of the picture of their health status, that doesn't really define the medical complexity of treating these patients, because they can still have a number of these conditions and have trouble getting to the clinic for any number of reasons. So in order to illustrate that a bit better, on the next slide, we've included this quote from a caregiver, in this case, a daughter of a patient, discussing how difficult it was to get her mother out of bed and to appointments at the clinic for any number of reasons. And this is just one of a number of quotes that we've collected as part of the evaluation, where we can see that these are needs that really are addressed by having the care happen within the home rather than within the structure of a clinic-based care. Another important thing to mention about this is that the program is not just aimed at the needs of the patient, but at their caregivers. So, as such, we wanted to understand who the caregivers are. So, in the next slide, we see that for this evaluation, we've defined a caregiver as someone who provides the majority of help with daily care and medical management as identified by the patient or self-identified. It's mostly self-identified in cases where we're not speaking directly to the patient, often in cases of a dementia diagnosis. So based on self-reported information from the caregivers, you can see that most are female and middle-aged. For race, the distribution is actually very similar to the one for the patients, which isn't too surprising when you look at the fact that most of the caregivers are directly related to the patient. And in cases where the caregiver is not the child or the in-law, which it is in the majority of the cases, or a spouse or partner, there's also paid staff or other. So paid staff can include staff within the facility that the patient lives, or a paid caregiver, and other cover cases where there's a friend or a housemate or someone else providing care for the patient. So now I'll pass back to Maria for the next section.
Thanks so much, Anna. And so now we want to look at some of knowing the diversity of patients and families helps us understand better the short-term outcomes that we're looking at, which include quality of life, functional status, caregiver burden, and satisfaction with care. Now we'll focus on those ones. We looked at patient and caregiver reported outcomes, mostly through surveys that we've collected either by phone or over email, and mostly from caregivers themselves, since majority of patients were either unable or unwilling to respond because of dementia or hearing impairment or other impairments that disallowed them to respond to the surveys. And we basically asked folks about their limitations in daily personal care, their household management, their quality of life, and then the caregiver burden for caregivers. You can see in this table that we looked at the average number of limitations, the average quality of life, and caregiver burden as it compares to existing literature for similar populations. And that's actually one of our questions is, we didn't survey any other patients or families, so it's hard to compare to see, what is happening in this program. Is that representative or is it uniquely different? But what we found in comparing to the literature is that our patients are much more disabled and have lower quality of life and higher caregiver burden on average, which I think is really important as we consider the resources necessary for the program to really address these issues. The next question we had is, this is at baseline and enrollment, but what happens as caregivers and patients stay in the program? So we asked patients and caregivers that after 3 months in the program and after 6 months to fill out the same survey. And we plotted these numbers over time, as you can see in this patient quality of life graph, where you can see the average number, the average quality of life remained fairly stable, slightly declining after 6 months in the program. So we don't expect there to be major changes because patients are so frail and disabled. But we still want to see, is there anybody for whom the decline has been less rapid because they've become more stabilized in the program itself? Similarly, when we looked at the caregiver burden, same idea, is we asked at baseline 3 months and 6 months, and then we found that the caregiver burden actually also remains high, even with the resources that we provide. And so in the interviews, we wanted to better understand, what are the unmet needs that caregivers have related to the program. Is it something that medical care can even address at all? Because many of the caregivers talked about, especially as we entered COVID period at month 6, that there became a lot of different challenges that caregivers had to face as they navigated caring for themselves and for the person, for the patient. And so we would love to hear what alternative clinical explanations you might have looking at these numbers. The other thing that we were really interested in was the satisfaction with care, which we started asking about after 3 months in the program. We asked both about, closed form questions, but also asking folks to describe a recent positive experience, a recent negative experience, and then anything else you'd like to share. And what we found are these 7 major kind of buckets or themes after looking at the responses that most of the caregivers provided. One of the things that is important and critical for any sort of care is communication. And we found that caregivers and patients have reported the excellent communication, for the most part, related to the issues that arise in the homebound population. The second most important theme was transportation, and really the quote that illustrates that is the first one. It takes so much pressure off me, mostly because he's in a wheelchair and has dementia, so does not always understand car travel, getting into and out of his wheelchair. The home-based program really kind of nailed this idea that, by reducing the need for transportation, we were able to get to patients more easily, reduce the stress, and increase their satisfaction with care. The medical treatment itself was really, many caregivers reported that medical treatment and the geriatric specific care was really critical. The continuity of care and the fact that our providers were able to follow patients as they went into a hospital or skilled nursing facility, as you can see by quote 2. one of the caregivers mentioned, they came to visit the patient during a 4-day stay in the ICU. Shortly after they came again to the house again, once he got settled and under hospice care. Their care quality and kindness is the best of the best, and we love them. So it really talks about this continuity and comprehensiveness of care as patients transition between different care settings. Somebody mentioned that this program avoided a hospitalization, which is something that we hope that this program would achieve. And you can see by the last quote is, I do believe that home care avoided at least one hospitalization over the past 3 months and assisted us with stabilizing blood pressure following a change in medication in a way that might not have been possible without home care. Coordination of care, as I mentioned, and caregiver support were other 2 themes that we surmised from the surveys, and that most of the caregivers have reported the additional support that they received through this program. When we looked at questions related to negative experiences or what could be improved, we find a number of domains as well, but you can see that in the green buckets are the themes that actually were highlighted to be positive as well, such as communication, caregiver support, and care coordination. So there were some people who were able to say, you know, this is excellent and great and it works for me, and obviously for some people it did not work as well. But it really speaks to the diversity of patient and caregiver situations where these comments, you know, we have to take with caution, because there's so many different situations that the clinicians have to deal with, and learn whether there's a one-off issue or is there a systemic issue that can be addressed through the design of care. Some of the areas for improvement was after-hours access, medication management, referrals, and education. And some where we even kind of these reach statements that they wish that the other services had care at home, such as specialty care or home infusions. But we, having identified these themes, we wanted to go deeper and find out more about what worked and what didn't, because the surveys give only a small snapshot. So we focused, and we're currently conducting patient and caregiver interviews with a diverse sample of patients to understand who benefits from this program and what care processes can be addressed and what are potential gaps. So we had to modify it during COVID, because of COVID, to be by phone only. But we hope that these interviews will give a more rich, in-depth understanding of the issues that patients and caregivers face. Anna, back to you.
So I'm going to wrap up quickly because I think we need to allot a bunch of time to Q&A. So just quickly, in terms of the other information we're collecting for long-term outcomes and acute care utilization, if you go to the next slide, Maria, we're planning to compare the acute care utilization of patients in the home-based senior care program to a similar group of patients who are receiving clinic-based primary care. And the most important thing to know about this one is the reason we chose to set up the analysis this way is that we really felt that to reach any meaningful conclusions as to any change in acute care utilization for the patients who are in the home-based senior care program, we needed to compare it to a similar group of patients and their acute care utilization patterns. And we're currently in the process of putting this comparison group together. And then for the next slide, the last piece of data we're collecting is related to the long-term outcomes of end-of-life and palliative care, specifically place of death and use of hospice. And as far as the patients who are enrolled in the program, they are doing far better than the patient groups, several patient groups that we found in the literature in terms of dying at home and using hospice, which is generally patients' wishes for their end of life. So we also want to note for this particular slide, we don't know the comparison group for the end of life data because we've been manually tracking place of death and use of hospice, which is why we have this literature-based comparison. So I'm just going to pass it back to Maria to wrap up, and then we can move on to the discussion.
Sure. So we basically, lessons learned so far is that our patients are more disabled than seen in the literature, but it's challenging to capture their complexity with existing EPIC data. As you can see, some folks who have zero comorbidities, and we know that's really not the case. But using validated research tools, we realize that it might not be applicable to the clinical population that we have. We also find it's really hard to identify caregivers for medical records, as some of you might know. And we again find that they tend to have fairly high burden scores. So we're looking, at ways that to address this issue through the clinical program. And lastly, the program itself is reaching its palliative end of life goals, as you saw in the previous slide. And now we're working on looking at the utilization itself. So here are questions one more time, and looking at comparing satisfaction survey results to individual interviews. Finding comparison groups for patient-reported outcomes, and any clinically relevant explanations for the outcomes you see in the program. And if you know how to find information on deceased patients in EPIC, we highly welcome that, and anybody else who might be interested in the results of this evaluation. So thank you so much for your time, and we really hope to get a productive discussion in the next few moments.
Well, thank you so much, Maria, and thank you, Anna, for your presentation and for really this amazing work that's so critical in the lives of these individuals and their caregivers. So we now have about 13 minutes, it looks like, to discuss. Just a reminder to everybody, as you think of questions or comments that you want to share, the goal of this part now is to help our presenters and help refine their thinking. So it's not about us, right? So you're probably really curious about a lot of great things. Why don't you reach out to them separately and you can get all those questions answered. But let's make sure we structure our comments and questions now that it can be helpful to them. So if it's okay, I'll start off with one, and then if people want to raise their hand or put in the chat they have a question, just let us know. One question I'll start out with is well, actually I'm going to start out with a question, then I'm going to have a follow-up question. So the first question is, what would you envision would happen to this work after, if you're successful? If you're successful in making this happen, making it, you achieve your objectives here in our environment, where do you hope to see this go next?
That's a great question. And I think one of the things that we are learning is we're just basically scratching the surface of figuring out, who and how to collect some of this information so that we can inform future evaluations, looking at other programs that are potentially similar, looking at similar populations of frail older adults and their caregivers, because I know that, for example, SHC opened a caregiver resource center, and they're also struggling with identifying caregivers. So we really hope to inform and cross-inform each other and kind of how and who are these people are, even just to begin with.
Great. And so then my follow-up question or comment would be, okay, given that that's what you're thinking, like larger scale, like where this is going to go if you're successful, what would you change now, or what would you do differently now in anticipation that you're going to be successful, right? Because this is such a potentially a fantastic program that we hope many people around the world adopt. So what might set you up for success for that next step that you could be doing now? You don't have to answer that in depth, but maybe think about it.
Yeah, that's again a great question. I think looking for the future, we really hope that we don't know if you're going to find the fact, prove the business case for this program, but we hope that it will continue to grow because, really, the reason why we're looking at utilization is to make sure that this program is sustainable in the long term. That's really kind of our major goal, is making sure that, once we prove its effectiveness, that we can grow it and maybe expand to other populations too. And then so what we would change now is really engage the stakeholders early on. And I think that's one of the reasons why we're presenting here, is to identify who can be other people who might be interested in kind of developing similar programs, maybe home-based palliative care, maybe home-based care for children with disabilities, and building early on and these connections across Stanford.
Great, thank you. Okay, I see, or I'm hearing that Marina Martin and Steve Ash have questions. Marina?
I don't think I posted a question. I could add
Oh,
a
okay.
comment, which is that
Go ahead.
when we were looking into building this program in the first place, we weren't trying to reinvent the wheel, really. We were bringing a proven program to Stanford that had been well studied other places and very successful. So a lot of the work we're doing is to figure out how do we make that work in our local environment. And others have really used this kind of home-based platform to do a lot of other types of work, as Maria was suggesting, whether it's palliative care in partnership with their primary care physicians and specialists, or hospital at home as a project that's been very successful in Mount Sinai, and particularly in the COVID era might be incredibly helpful. And also there's a lot of move within Stanford toward value-based care models and participation in value-based care programs through Medicare and other organizations. And all of that, I think, will increasingly encourage us to go this direction toward providing home-based care for those for whom it's the appropriate type of care.
Thank you, Marina. And that's great. So if your next steps then are more locally focused, then I think that's great to be thinking about that as well. Steve, did you have a question or comment?
Somewhere between a question and a comment, I imagine. So great work, Mia, on the comparison group is very difficult here. I'm sure you've had a lot of thoughts about it. I've even had conversations with you, Maria, about it. I think, Marina, you're right. I think we are going to have to depend on the literature to say that it is an overall effective program, because the comparison group is going to be so difficult to construct. But it's always a question of targeting, right? Which is the population that is going to benefit most from this sort of intervention? And so I just want you to, if you guys don't mind, just kind of surface your thinking more about what kind of comparisons we could make, either to the literature or to other Stanford patients or even non-Stanford patients.
Great.
Yeah.
Any response?
Yeah, so we're doing kind of a two-pronged approach, one of which is for utilization. We are able to identify a group of somewhat comparable patients, or we're currently working on that because coming from primary care clinics and senior care clinics. So I think we'll be able to answer the question about utilization because we're able to collect that information. I think in terms of, for example, end-of-life outcomes, it will be much harder to do because we don't have that data. At least we don't know if it's recorded anywhere in Epic consistently, because we've been just collecting that information, manually, and that's where we are relying on the literature to be able to make these comparisons, like we showed in the previous slides. And then for patient-reported outcomes, I think it's such a challenging kind of outcome to begin with, because there's so much diversity, and as you can see, it doesn't, both we and others in the literature have found that for some people, caregiver burden does not budge, or it budges very slightly. And same with quality of life. We don't expect there to be huge improvements over time because folks are just already so impaired. That I think we'll just have to, look at, more qualitatively, and look at, how folks, how patients and caregivers self-reported and take it as face value.
Well, I think the qualitative results are going to be absolutely key no matter what. Utilization, I would imagine they're going to be useful. For utilization, I think we talked once a long time ago about potentially doing propensity matching rather than matching just on those 3 variables. I think it would be more likely to be closer to the truth anyway. So the qualitative stuff is I think what is going to really tell people within our institution that this is something that they want to keep doing. So minimize that in any way. Anyway, just want to echo what a lot of other people have said. This kind of evaluation is exactly what we need to figure out how to move forward for big programs like this. And you guys just did a great job.
Thank you.
Jay, I think you had a comment or a question.
Yeah, thanks, David. Really nice work, team. I think this is great to see. I already forgot. Oh yeah, my question I was initially writing was about if you're trying to look for a comparison group, given that COVID has hit basically in the middle of year 2, and so many of the patients that would be in whatever comparison group you pick were relegated to essentially adopt some form of home-based care, whether it's telemedicine, et cetera. Is that going to pose challenges as far as you measuring benefit? But before we even answer that, the more useful question I just thought of as I was sitting and listening was, I remember seeing a study, it was on, I think it was for heart failure patients, and it was going to be a randomized trial, and that's not what we're talking about here, but there was a really robust discussion about what is a useful metric for whatever the 2 interventions were. And they had a whole bunch of experts in the field get together and talk about the usual metrics that we always throw out there, survival, et cetera, coronary events. And then after they sort of preliminarily decided what they were doing, for whatever reason, they had the very bright idea of engaging some patients and caregivers and said, what are metrics important to you? And it actually turned the entire trial on its head, because they realized the patients don't care about any of those things, and that the ultimate outcome they ended up picking was days out of the hospital. Basically, how many more days did this intervention allow me to spend at home versus in the hospital? So I wonder if you in this group have the opportunity to think about something a little bit more unstandard as well, as far as what is really important to these patients. What's an outcome that they would say, hey, this was so great. Over this last year, I did this program and it gave me this, whatever. Days out of the hospital doesn't quite make sense, but maybe something along those lines of something that any patient would look at and say, wow, that's a cool benefit. I can wrap my hands around that. So you can ignore my COVID comment, because like I said, I'm much more interested in this one.
Yeah, no, I think it's a great comment and a great suggestion. And we definitely see, comparing, our, for example, quality of life outcome, that's, valid, reliable tool that's been used a lot, and everybody seems to be doing poorly according to it. But when we talk to patients and families, they give us a slightly different story. It's still a hard, it's really hard caring for somebody who's homebound. But I think there's also some success stories and opportunities, for example, for extended family to visit the person in the home and be able to stay at home as long as possible and not go to a nursing home, or be in boarding care and kind of reduce the impact on the wife taking care of the patient at home. So having the home-based senior care team helping coordinate these different opportunities for the better. So we definitely, through the qualitative interviews that we're conducting now, we hope that we'll be able to get a more bigger picture what patients and families want and like about the program. Because we know that transportation is important, but it's not just the only thing that's important. There are other benefits that we hope that we can flesh out. So, and maybe for the future studies that or future projects that we have, we'll have a lot the patient voice up front. Except right now we kind of, doing it concurrently, but I think having the patient voice up front is always important.
Great.
Thank you so much. Well, I think we're about 2 minutes before the hour, so this might be a good time to say thank you and go ahead and wrap things up. Maria and Anna, I think we all agree that this is just really outstanding work, very important, unbelievably important to these individuals who you're targeting. So thank you for your fantastic work. Those who had additional comments or questions, please do feel free to reach out directly to them. And thank you also for joining us for this second of our speaker series. So we really appreciate it. Thank you again.
Thanks everybody.
Thank you, everyone.
Really cool work.
Good job.